on this really important subject. So I want to give you a warm welcome and hand you on to Bill.
Thank you, Ashok. So just a word. So first, to repeat Ashok's thanks to Anna and David in particular, both for convening this first seminar and for your success in pushing forward this program, as David is, I think, going to describe to us, David and Anna are going to describe to us later on. So it's a very exciting program for us, and we're very pleased to welcome everyone. Just on a practical thing, we've found with these webinars that it seems to work best if we have the presentations followed by discussion rather than question and answer after each session, after each presentation. So David and Anna, forgive me if we've got this wrong, but I think you're going to plow through the program and then we'll have a solid discussion session at the end. You don't need to wait to the end to raise your questions. You can put them into the chat line at any stage. And then Mihir, who is administering the program today, will be picking those up for Anna and David. And that will be a chaired discussion session that will start at about, according to plan, about 11:20. And so we should have plenty of time for discussion at the end. And indeed, I think it's part of your aim in this meeting, Anna and David, isn't it, that we should really be discussing these issues. We've got some ideas to present, but discussing both the specific issues around personality disorder and also the wider issues of public mental health, what it might look like as we come out of the pandemic. So over to Anna, who is going to take over from here. Anna, you need to unmute.
Yes, so welcome to today's proceeding. My name is Dr. Anna Bergvist. I am a senior lecturer of philosophy at Manchester Metropolitan University, and I work very closely with David Kravesky for this particular initiative. David Kravesky is very well known for his pioneering groundworking work in peer support, and indeed also for patient empowerment for over 30 years in his work for the Mental Health Foundation. He's a very known scholar also in his own right, thinking specifically about recovery and peer support and self-management as tools to support that concern for us all here today. So David and I will be leading this program today. One of our speakers, Ray Middleton, has pre-recorded his session today. Dr. Ray Middleton is an independent trainer at Ladder for Life and the Workforce Development Lead for the Fulfilling Life program in Newcastle and Gateshead. There he's piloting a training program of trauma-informed training, taking a dialogical approach towards staff development using a social psychological framework that he himself developed. Ray has a PhD on dialogical and narrative approaches to complex trauma and has written a chapter for a book on innovative approaches to people without a home. This paper is called Cross-Cultural Dialogues on Homelessness. Previously, Ray has set up and managed personality disorder services. He's also been a senior care coordinator and early intervention in psychosis services, and is also a systemic practitioner with a systemic family therapy orientation. Ray himself has personal lived experience of surviving trauma. He has used substance misuse and mental health services in the past. And it is also this experience that motivates him to improve staff skills and indeed services for others in the future. So I will pass over to David now.
I think we're going to go straight into the video from Ray, so we'll take Ray's contribution first, and I will come after Ray.
Hi, I'm Dr. Ray Middleton, and thank you to David from the Mental Health Foundation for inviting me to share a few thoughts about what might be helpful in developing a public mental health approach to improving our thinking around personality disorder. So at the moment, I work for Fulfilling Lives I write and deliver training. So I'm the workforce development lead, and I've done that for a number of years. But in the past, I've also been a care coordinator in an early intervention psychosis service, and I've managed personality disorder services before that. And so I've got those sorts of experiences as a professional working, and I've done a PhD looking at personality disorder and narrative or dialogical alternatives to the medical model. But before that, in the 1990s, I had a particularly troubled journey through life, I suppose you could call that as a metaphor. And I ended up having lots of problems. So I was unemployed for 5 years, and I ended up in the mental health system being assessed. And the way that kind of discourse works, narrative works, is it's a genre, isn't it? The mental health, the medical model in mental health. And you can imagine all the genre is like a general set of expectations about what's going to happen. So if I said the kind of medical science approach to understanding mental distress, you could think that maybe doctors and nurses, hospitals, medication, diagnosis, that type of typical things are going to come up in the plot. A bit like the science fiction or a horror genre. You could expect a few typical things to come up. And those typically expected things did come up in my journey. So when I got assessed, I got a diagnosis, and a diagnosis initially of bipolar affective disorder. But then, as I didn't get well, I didn't recover. What happened was I got caught up, as some people do, in a narrative. We can get caught up in a narrative, can't we? So once I was seen as mentally ill or mentally disordered, and I didn't get better, I ended up being an inpatient in the psychiatric hospital. And then a cycle happened where I kept being struggling. I used alcohol and drugs as kind of self-medicate because I had a lot of anger and guilt and shame about being sexually abused as a child. I did tell people at the mental health assessment this. But their approach, which is based on their training in that particular approach, is to look for symptoms of a disorder and then diagnose people. And so I ended up seeing myself as my diagnosis, really, and this isn't unusual. You know, some people find they get better and they use aspects of the medical approach, the medical model, to kind of integrate into their narrative of getting better. And they might say, oh, well, I realized I had this problem and then I did X, Y, and Z. Other people get better and their narrative that develops their personal stories in resistance to that because the medical model. And I'm in that kind of range. I found I got caught up in the medical model. I saw myself as a passive patient, and the problem with the medical model I found was that initially it relieved a lot of anxiety, because why was my life so difficult and why had I got all these problems? Well, here was a solution from this narrative, which was saying, well, you're mentally disordered, you've got a mental illness. I got 7 different diagnoses, and the last one, once I got kind of caught up in 7 different admissions to the psychiatric hospital, was to say I had borderline personality disorder. But actually what I'd said to the original psychiatrist and the other ones that I saw was that I'd been sexually abused as a child, and that had gone on for a long time, and I'd responded to this by feeling angry and anxious and guilty and ashamed, and I'd used alcohol and drugs and self-harm to cut myself and overdosed as a kind of coping mechanism. So having got caught up in that world, and I'm illustrating the point about that's a very narrow approach. It's the dominant model, so it needs acknowledging. And there's lots of critiques of that model. It was clearly, there's lots of evidence around in the 1950s that approach didn't work. But that hasn't prevented it from maintaining its dominance of the way to make sense of serious mental health problems is to go to medical science. And that narrative, which has those characters and those typical outcomes, categories, diagnosis, medication, treatment, etc. But what I'd suggest would be helpful from a public health approach, having kind of reflected on this, is to see, have a dialogical approach. So that's from a guy called Mikhail Bakhtin. And there's lots of dialogical approaches to different things in life. So open dialogue is an approach to severe psychosis developed in Western Lapland by Jaakko Seppälä and others. And I was privileged enough to help to run a small open dialogue pilot. I chaired the working party in 2013, and there were lots of other people involved in that, and that was really helpful. And that's a non-diagnostic approach with very low levels of medication, which involves people's social networking, making sense of distress. So open dialogue is an alternative to the diagnostic approach. And there's lots of other approaches that a public health approach would need to be aware of, I would suggest, is helpful, like trauma-informed care. Looked at the adverse childhood experiences studies, has found how common trauma is, and then trauma-informed care educates generally staff in services and also the general public in organisations to have a trauma-informed approach, trauma-informed practice. So that's another approach which helps to kind of say it's everybody's business to understand the impact of trauma. The psychologically informed environments, or PI, has been developing now for about 10 years. There's Robin Johnson has developed them at pilink.net, and there's lots of free resources at pilink.net. And PI is a way to help homeless services, for example, to develop, and I've been involved in developing PI and training people around trauma-informed care for a number of years now. And PI is a way to help services, often staff in homeless services who aren't paid very well, often not trained very well, to start to think about the work they do with people who have high levels of trauma, often who attract a diagnosis of personality disorder. But traditional mental health services aren't very good at helping. And so the idea is there's a range of things. I'm just kind of flagging up a few here. If you took a dialogical epistemology, which says that it's not just about trying to have a monopoly, like the game of Monopoly, where one person wins all the money and everybody else loses. Instead, narratives that can help our genres, general set of expectations, that can help people make sense of distress. There's many out there, and a dialogical approach would be a good starting point in terms of epistemology, and using Bakhtin would be my suggestion. And there's examples of that in practice, such as open dialogue, etc. There's some pilots in the UK now, been running for a couple of years. But those approaches are also available through the trauma-informed care. The other approach that comes to mind is the power threat meaning framework by the British Psychological Association would be really worth going for, in terms of not making the mistake of having a public health approach which says, try and have a good diet, exercise, and some self-care and a bit of this. But if it's getting a bit tricky, see your GP and get referred into in my experience, the beast that is going to diagnose you, give you loads of medication. In my case, put on lots of weight because of the side effects of medication, sometimes stop me breathing because I had reactions to the thing. And so you end up, dying younger because people get diabetes from the weight gain from the medication. So, I'm not saying medication sometimes can't be helpful, but in general, let's be honest, the benefits of medication are exaggerated, and the downside is played down by the professionals involved in prescribing. And there's lots of evidence around there. You can look at the website Mad in America, for example, has lots of access to different critiques of that approach. So what am I saying here is, on the one hand, I think we need to acknowledge that for lots of people, the medical science approach, the dominant approach there, diagnosis, is unhelpful and damaging. The range of people, some people get caught up in it like I did, and then you find a narrative to escape and ways to get better. So a public health approach needs to avoid kind of just falling into that trap of trying to funnel people towards there. And epistemologically, a dialogical approach based on Bakhtin would be a good starting point to avoid epistemic injustice, where you give all the power to one particular way of looking at the world and medical science and think, devalue all the others, because there's tons of other approaches to making sense of mental distress. For people like myself who are attracted to the diagnosis of personality disorder, there's political kind of approaches, like you might get involved in all sorts of stuff. In the 90s, I got involved in protesting about climate change. People did think that was a mad thing to do at the time in the 90s, but now it's quite popular. So everything's historically contingent. If you wait long enough, these things become, change. Things change because ideas are historically and culturally, socially contingent. They're not stuck in science, stuck in time in the fact that we're just peeling back the truths. It's power and knowledge is all interwoven, and there's vested interests and there's struggles around it. So there's lots of other things, peer support, Narcotics Anonymous, Alcoholics Anonymous, and lots of others, peer support around recovering from trauma. There's philosophical approaches, there's faith-based approaches which offer narratives which can help people to make sense of distress and techniques to get better. So for example, my experience, people's experience of getting better varies. So not everybody gets better, lots of people die. I've just been involved in a service where 10% of our clients that we supported with multiple and complex needs or multiple disadvantages, 10% of them died. Often they attracted a diagnosis of personality disorder or met the criteria, but it was virtually impossible, apart from 1 or 2 rare cases, to get the people into secondary mental health services, which was tragic. But they're just not geared up for helping people with more complex needs. And so 10% of our clients died fulfilling lives in Newcastle and Gateshead, which was shocking. But to change the system, to think systemically is helpful. To change the system takes time. And there are good ingredients. We can be really positive. It's not just about deconstructing and flagging up how people can get trapped in these, the medical diagnostic approach. There's lots of other approaches. So listening to people's personal stories broadly is what helps in developing personal narratives, because human beings are social and relational and ethical beings, and we see ourselves in a narrative. And if we're stuck in a narrative, like I was stuck in seeing myself as mentally ill, as diagnosed with personality disorder for a few years, and then for me it was a faith approach. I became a Christian, and that helped me to make sense of the resentment I had, and I forgave people, and that freed me up from feeling resentful and needing to use alcohol and drugs and cut myself to cope with overwhelming feelings. Now, I appreciate other people might find other narratives to escape, but what you need from a public health point of view is to value that range of things out there that could be helpful in making sense of the personality traits that attract that diagnosis. And if we think about those traits, they tend to be, my take on this was, the traits are there. Let's not pretend that people don't have very distressing lives and can be distressing to the people around them. So when I was very troubled, I used to end up in and out of the psychiatric hospital many times, or A&E, self-harming, overdosing, lots of problems. So it was an awful life. It's very distressing, and distressing to people around me who cared about me to think, well, what could happen? But partly they've been disempowered by thinking, oh, it's very complicated what's wrong with Ray, keeps getting these different diagnoses. What was helpful from a public health point of view is to empower the average person to be able to think you can be helpful by listening to someone about their narrative, their story, and help them develop that narrative, so narrative competence. And how do the personality traits affect people's social function is a reasonable question, but you don't need a medical science approach to that. So most of the personality traits that affect social functioning are, in my view, about too much or too little of something. Too little self-control, too much guilt, too much anger, the repetitive excess of alcohol and drugs, like addiction type problems to cover over distress. So what helped me is to have a trauma-informed approach, to see that it was my reactions to trauma, so a power threat meaning kind of framework would help with that. They'd ask questions like, how's power operating in your life? And are these understandable reactions to trauma, the habits that I developed? So we develop these personality traits or habits, some of which can be skills and some of which are unhelpful habits. And you can find a language to talk about that. I think you need to see that these habits, and there's about 70 or 80 of them clustered around what people call personality disorder, but these habits of repetitive excess, we need techniques of the self. So Foucault has this idea about techniques of the self, and that could be a useful kind of concept from academia to think about, in terms of Foucault's writing around ethics, the history of sexuality is quite helpful in terms of what is it, how can we work on ourselves to change ourselves, to have not too little or too much of something, but that kind of moderate idea, which is seen as skillful. And so we need some helpful narratives that allow us to think about ourselves and to change in a community of other people, and that offers some helpful techniques of the self, to use a kind of academic concept, is quite helpful to think about excess and insufficiency around those habits. And also, it's not written down anywhere what is ethically too much or too little of something, because society always changes as well, doesn't it? So what was thought of as too little concern about too much concern about the environment now is like, oh, well, climate change is a real thing. So things change over time about what people value, what traits or habits are seen as skillful, like being reliable, a good listener, and patient are examples of habits that are valued. And what's too much or too little? But actually, when two people meet with two unfinished personalities having a conversation, so I might think, yes, I think you're annoying, but actually it might be my lack of patience. So you see how these personality traits are dialogical, so treating them dialogically and in opening up a dialogue about these traits. So why is this cluster of traits causing you problems with social functioning? So it might be this type of society is kind of expecting X, Y, and Z. It might be a highly consumer capitalist society that's expecting some things, and then I'm not fitting in. So it doesn't prescribe a solution, but it says, let's be able to talk about our personality traits or habits in terms of a mixture of skills and things that are too much or too little, problematic. And let's say that we all have difficulties. We all have difficulties. I've got some issues because I'm a human being. You have too. Whether or not we admit it, so human beings have issues. So the skillful thing would be able to talk about narratives, offer a range of narratives that people can escape from a narrative if it's not working. Just give it up. I should have given up some of the narratives I got involved in a lot sooner than years of kind of persevering with a narrative that's not working. Health narrative is supposed to cure you and get you well, so it hasn't done that in a few months. Look for a better narrative, a believable narrative to escape from one into another, and then once you're in a believable narrative, find out what are the techniques of the self to work out how are these personality traits of excess and insufficiency affecting my ability to social function, and then find ways to find community and belonging. There'd be a few thoughts from Bakhtin, the moral ethical side. There's a guy called Taylor. It's quite helpful as well. And then Foucault, the ethical side as well, around too much or too little, and opening up a dialogue around those personality traits would be my kind of suggestion about a few ideas that might be useful in developing a public health approach to better thinking around the issue of personality disorder. Thank you.
Okay, so after that very inspiring start, we will now move on to my great colleague, Dr. David Kravesky. Dr. Kravesky has been working at the Mental Health Foundation for over 15 years to create a strong and effective voices for people affected directly by mental ill health, and has led the development and delivery of major programs around self-management, carer involvement, and peer support for people with a severe psychiatric diagnosis. He's also championed mental health awareness training across the UK and further developed national user involvement mechanisms in England, Scotland, and Wales. David has also led the Mental Health Foundation's own patient and public involvement activities, working as a co-investigator with a range of academic partners on research council-funded projects. He has substantial personal experience of using mental health services and has applied this experience and learning from it in a systematic and productive way in order to improve outcomes for people with experience and who do experience mental ill health. He's been a technical advisor to the World Health Organization, a serious mental health advisor to Public Health England, a member of the Ethics Committee of the International Society of Psychiatric Genetics, and further written a mental health module for the Open University. He continuously writes, speaks, and campaigns for improvements within the mental health services. Finally, as the newly appointed head of applied learning, David will also take a very active role as supervisor for the advertised PhD studentship. And in this role, he has already started to develop the foundation's work on taking a public mental health approach to areas traditionally regarded as severe and enduring mental illness. So with that rich, long CV, I will hand over to David.
Lovely. Thank you very much, Anna. Can I just check I'm coming through, because my video has just chosen this moment to freeze.
Yes.
Okay, lovely. Thank you. Well, thank you very much, Anna. I should start by saying that this seminar series and the associated research project and doctoral studentship come as part of both a kind of dream and a nightmare that have combined, really. And over recent years, there has been increasing evidence.
Just as a, sorry to interrupt, but could you just stop your video and start it again? It's not.
Yes, of course. It's
there we go. It's perfect now.
Oh, okay.
Yep.
That spontaneously happened before I'd started and stopped it. Is that better, Mahir?
Yes, it is.
Thank you.
Sorry to interrupt.
So, no, that's fine. As many people will be aware, there has been a growing increase in the subject of public mental health. And that has led to two things. Firstly, it has led to an increasing focus on the topic of prevention and how this can be applied in a way that makes quite a lot of sense in physical mental health, although it is fair to say it's taken quite a long time for it to make sense in physical mental health, and how we can apply that to mental health. And secondly, and more importantly for me, as someone who has spent most of my time thinking in the space that typically gets thought of as serious mental ill health, and trying to encourage us away from simply thinking of that in a classic biomedical approach. On the one hand, initially, public mental health feels very much more attractive as a space to be in, but it's also very problematic to simply transfer our thinking around what gets called serious mental ill health and place it in a public mental health context. And when I am faced with challenges like this, what I like to do and how I like to approach it is to really just encourage a conversation and to start to unpick what it is that either excites or annoys me and other people about this developing initiative that we call public mental health. And I am hugely indebted to Sarah Stewart-Brown in this endeavor, and I have a horrible feeling that she may actually be in the seminar. And so I'm going to tread very carefully and hope that she will be kind and compassionate in her any kind of critique of my critique of public mental health as we go along. But the
David,
public mental
just before you move on, can you try your video? There we go. Thank you.
Is it being continuing to be problematic?
It seems like it. If it stops again, I won't interrupt, but right now,
okay. And classically in public health, there are a number of key pillars that we rely on. And one of the challenges we have in public mental health is that not all of these pillars that are well established and work well in public health transfer neatly and easily into mental health. So I'll start by just naming and framing these key elements of public mental health, and then try and look at some of the challenges in transferring these into the more severe mental illness space. I should also caveat this by saying that I am not naturally comfortable using phrases like serious mental ill health or severe and enduring mental illness, because it is not my natural way of thinking about these things. But at the same time, I recognize that it is some people's way of thinking about these things and framing these things. And the important part of developing a public mental health approach to this area is that I don't want it to exclude people just because of their choice of language. So I am naturally using language that I'm sometimes very comfortable with and sometimes less comfortable with. And that will probably show in my tone of voice. But this really is genuinely about trying to unpick some of the challenges. And one of the reasons why today's topic is personality disorder as a starting point is because it's one of those areas that does get put into the pot of severe and enduring or serious mental ill health, but there isn't a classic orthodoxy about how it should be treated. So our hope in starting with this is that we start with something that on the one hand feels very difficult and challenging as something to develop a public mental health approach to. But on the other hand, we don't have a huge amount of a job to do in dismantling an existing orthodoxy. And I think one of the challenges in a lot of areas of severe enduring mental ill health is that there are strongly held views and there are orthodoxies which just don't fit particularly well with a public mental health approach. And so by starting with personality disorder, I hope that we can sidestep some of that dismantling job and just focus on the tricky business of building what we might mean by a public mental health approach. So the four key components that are often thought about in public mental health, in public health rather, are health promotion, disease prevention, health protection, and healthcare quality. And instantly, I can see why it is not a straightforward process to move from that classic approach to public health to an analogous public mental health. And I think my starting point with these difficulties is the one that certainly we have been confronted by most frequently at the Mental Health Foundation when we have talked about public mental health, and that's this concept of disease prevention. And I think there are in mental health there are two really distinct challenges around that. But first is just the notion of disease. And classically in public health, we really do know what we mean when we talk about disease. And most of the issues that public health has tried to address are reliable, valid, identifiable diseases that have a kind of coherence as a condition. And that just really often isn't the case in mental health, whether that is, and I think it's particularly not the case in things that get called severe and enduring mental ill health. And in this respect, I'm thinking very much of personality disorder, a diagnosis that when I was going through the the mental health system in my teens and early 20s, we referred to as psychiatric sacking, or the dustbin diagnosis, the place you went when people had given up thinking of what it is that was up with you. And I think that makes a disease prevention model quite difficult. It becomes tricky again when we think about things like psychosis, and in a later seminar we will come back and talk about psychosis in much more detail. But again, it is not a straightforward, simple disease, illness or condition that matches that lovely public health model that we like to work with. And the second thing that makes that kind of disease model difficult is something that is certainly not unique to mental health, but is one of those things that has created problems in public health, and that's the stigma associated with diagnosis. And we do see that in other conditions. And a very good friend of mine worked very hard in mental health, in health promotion around HIV and AIDS, and the stigma associated with HIV and AIDS was a huge barrier to good public health initiatives. So there are places where the learning, even from the disease model, can be helpful. And then when it comes to prevention, we need to routinely remind ourselves that prevention is commonly thought of in three ways. There's a primary prevention, which is about preventing the appearance of a disease. There is secondary prevention, which is about reversing a condition, and there is tertiary prevention, which is about mitigating the impact of a condition. And even where we may not necessarily adopt wholesale a disease model for, say, personality disorder, we should still be able to think about what things like secondary and tertiary prevention might mean in that. And I would argue, certainly in the case of thinking about things like psychologically informed environments and trauma-informed approaches, that you could even start to think about primary prevention in this space. But it does need thinking about in an open and flexible way when we start using the language of disease and disorder, because what we don't want to do, and particularly what I don't want to do, is exclude people or turn people off from engaging in this discussion because they don't buy into a simple biological model, which indeed I don't. So that's the disease prevention thing, I think, is particularly problematic. In terms of the health promotion, one of the nice things about health promotion as a public health approach is it does tend to focus on the positive. It does tend to focus on things that are strengths and values within people. And again, this is something where I think there is a natural ability to start thinking about what health promotion might mean for people with diagnoses or conditions that are seen as more serious, and in the context of today, in personality disorders. This whole area of health promotion is something where we have started to do some work, and in my 3-year stint doing a part-time secondment at Public Health England, what became clear is that there was a real appetite for health promotion in mental health promotion, but it seemed to be very comfortable in talking about anxiety, stress, mood, and possibly even sleep. But it found it much more difficult to talk about what health promotion looked like as we moved into those things that were seen as much more problematic. in mental ill health terms. So Public Health England was very comfortable and creative and successful in taking a health promotion approach to low mood bordering on depression, to anxiety bordering on clinical anxiety, and sleep, which I think is a really important mental health topic, but it stopped short and didn't really know how to move into the kind of space that that we're talking about today. And that is precisely why I wanted to address this with this seminar series and this particular research project. The two other key pillars of public health, health protection and healthcare quality. Well, healthcare quality is something that we are familiar with, and Ray has already touched on this in terms of how we look at our mental health services and how we think of those, start to think of those much more holistically, and think of those much, move away from this kind of old-fashioned model of institutional care and treating disorders into how do we support people to live the lives that they want to in the context of either living with a condition or living with a diagnosis, depending on how you choose to frame this. And I think in terms of health protection, this is where we really need to start to understand the social determinants in mental health. And a lot of work has been done around the social determinants in mental health, but where we are genuinely struggling is with the complicated nature of interplay between causation and correlation. So we know that there is a strong correlation between social deprivation and incidence of severe and enduring mental ill health. We know that there are correlations across lines of ethnicity. We know there are correlations by postcode. We know there are correlations by whole ranges of things, but untangling those into actionable causal links is much more difficult. Now, there are some things that just leap out as being straightforward health protection approaches that should work very well with severe and enduring mental ill health, and they are certainly those that might focus on minimizing trauma. I remember once having a conversation with a head teacher about how they could turn their school into a genuinely mentally healthy place to be. And I said, well, probably I think that the simplest thing you could do would be to have a really good and effective response to bullying in your school. And that's where this head teacher and our discussions came to a rapid halt, because she said, there is no bullying in this school. And I think that's when it becomes that's when you cease having a dialogue. But my point in raising that as an issue is that in a sense, it doesn't matter too much whether there is a very strong causal link between bullying and personality disorder, but an effective interventions that reduce the amount and impact of bullying are just going to be genuinely beneficial. So you have to kind of, at some points, you have to take a little bit of a pragmatic approach with this business of correlation and causation. I think I am now coming towards the end of my time. I wonder if someone can prompt me for time, because I've just lost track of my clock. I think if we are happy to do so, I will bring it to a close. Bring my presentation to a close now. Thank you. I would encourage
Hi, David, can you hear me?
Yes, I can. Did I lose video sound then?
A little bit, probably.
Okay. So I would now like to introduce a very good colleague and long friend of mine, Alison Faulconer. Alison is one of the people who's really pushed my thinking in this area. One of the things I adore about Alison is that she always tells me exactly what she thinks of what I'm saying. And you know, 8 times out of 10 that's very positive, and 2 times out of 10 she is quite rightly picking me up either for jumping to conclusions or making false assumptions, or just being plain wrong. I'm now just going to sorry, bear with me, I have a slight technical problem on my end. I'm now going to introduce Alison properly. My apologies, Alison, for this. Anna, do you have Alison's intro to hand?
Would you like me to just introduce myself?
Could you, Alison? I am so sorry. I've had a minor technical meltdown this end. Okay,
no problem. Thanks, David. Thank you for inviting me to speak today. I have the dubious privilege of having received a diagnosis of borderline personality disorder, or rather emotionally unstable personality disorder, at some point in my psychiatric career in the past. I'm no longer using mental health services, I'm happy to say. I don't know what that says about my personality and its disorder, but I'm happy to say that I'm not using mental health services anymore. But I have had a number of mental health admissions to hospital. And so I've also been for some time a survivor researcher. So I work in the research world from a perspective of having experienced services myself. So basically that means that I'm really interested in how do we bring experiential knowledge to the table when we're looking at mental health experiences of all kinds and treatments. And David has really challenged me to think about public mental health, and it was really interesting to hear Ray's talk as well. I think I've got quite a few threads in my talk that overlap with Ray's, which is quite useful. But yes, David has really challenged me to think about this, because I don't think, I've tended to think in a mental health service related box a lot of the time, not necessarily all the time. But so I'm just going to move to tell you basically some of what I'm going to talk about today. I'm very much informed by friends and colleagues who've also experienced this kind of diagnosis, and also research that I've done around people's experience of therapy, people's experiences of abuse and trauma. And so I feel that this is informed by a range of different experiential knowledge sources. What I'm going to talk about today, but also artists and cartoonists, I hope to be introducing you to as well. I called the talk Bringing Personality Disorder Out of the Shadows, because the first 2 things that I read when I started preparing for the talk both talked about this diagnosis being in the shadows. And I'm basically going to take you through, how do we get this diagnosis? We've already heard from people about that. Some of the gaps in our knowledge, and what a public mental health response might look like. First of all, what do we talk about when we talk about mental health? Well, as David touched on, very often it's the publicly acceptable face of mental health. Mental Health Week, Time to Talk, Time to Change, all of those campaigns that introduce us to the idea that people can talk more easily about depression, about anxiety. More often it's about those elements of mental distress. that people talk about, and mental health, public mental health strategies tend to, as David also touched on, tend to find it much more comfortable to talk about the sort of understandable, if you like, measures, the understandable sort of face of mental distress, mental health, mental ill health. All this language is kind of inevitably complicated, but they don't talk necessarily about the psychoses, the other sorts of diagnoses, and personality disorder is certainly one of the most difficult, one of the most stigmatized diagnoses. And the shadows I'm talking about have been created by both public and professional attitudes. Just a few days ago, somebody who I know told me about a therapist who had described a member of staff as having borderline features. Now that to me is way overstepping any kind of professional boundaries and marks that is acceptable in these terms, in this world about that I would like to see in the future at some point. To sort of, what we do when we create a category like this is that we assume everybody has the same sorts of features. We start to minimize our nuanced understanding of individuals, and instead look for a broad characteristics that are in keeping with the other characteristics that we have listed in our diagnostic category. So we have people who are in very powerful positions, not just psychiatrists, but also therapists who can name and act as gatekeepers to services. And very often personality disorder, borderline personality disorder is what I'm usually talking about, being one of the most commonly used ones. But very often services are they're very often not available to people. I've seen people's experiences of being, refused admission to a hospital even when they are suicidal because they've been suicidal too many times. And therefore they are the risk versus the responsibility is being put into the balance, and people are being, if you like, persuaded at the wrong, basically this intervention is at the wrong moment, in the wrong way, at the wrong time, in every possible way. So we know that, as Ray mentioned, about 10% of people diagnosed with borderline personality disorder in this particular case will die by suicide, very likely. We also know from a number of studies, and these vary, 80% is an approximation only, because some studies show different numbers, but maybe about 80% of people who reach that kind of diagnosis have experienced some kind of trauma, abuse, or neglect. And I want to invite us to take a really broad understanding of what trauma means. In my personal life, trauma is also intergenerational trauma. So you might have parents who've experienced trauma in their early lives, and as a result of that, they are unable to convey certain beneficial emotions or ways of coping with emotions to the next generation. There are all sorts of ways in which trauma can affect people. So I'd like to include in trauma life events and intergenerational trauma that maybe aren't always assumed to be part of it. Not everyone who has a personality disorder, for example, has experienced sexual abuse in childhood, which is one of the most common sort of assumptions, I think, about personality disorder. And it is something that we need to be aware of. How do we get this diagnosis? Well, I certainly know a few ways I got it. Resistance to medical interventions. Perhaps we don't respond to antidepressants in the way people would like us to. A failure to recover. We keep being unwell. We don't take our pills and go away and get better in the way that the medical model encourages us to think about. So it's a real sort of dilemma for practitioners. A failure of services that turn us away and give us more iatrogenic trauma as a result of the ways in which they think it's a good idea to treat us like naughty children. Symptoms or behaviour that people don't understand or can't sympathise with or empathise with. So there you have, this is Rachel Rowan Olive, who's a really brilliant, I think, cartoonist and thinker, researcher, activist. So these are some of the ways in which you can get a BPD, borderline personality disorder diagnosis. You've made a few suicide attempts, self-harm, suicidal thoughts that are persistent. Your emotions change quite dramatically. Sometimes you might be impulsive. So there she has crossed off all her. And then what is her prize? An insulting label and a lengthy wait for therapy. Because actually, various forms of psychotherapy can be helpful to people with problems of this nature, which I really, really resist calling personality disorder, as I'm sure will become evident. But problems of this kind that are fairly long-standing, sort of, and really problematic, can be really very, very difficult to manage. Therapy is often a way that can be helpful, but it can be really long-term therapy. And sometimes that's not necessarily available to very many people at all. What are the gaps in our knowledge? One of the biggest problems about the biomedical approach and our categorization of people into diagnostic categories is it fails many people and it individualizes some of the massive social inequalities that we live with, that we all live with. And I think, you know, that has been touched on by both Ray and by David. Previous research has focused almost entirely on individual, the nature of the individual or the family, the immediate family. And it neglects to look at the systemic factors. And this is a paper that I read by Cameron and others, 2019, neglecting to consider systemic factors such as the impact of discriminatory health and mental health care practices. So whole social and environmental and political incidents in the world that affect us. Not just poverty, discrimination, abuse. Let's bring abuse out of the shadows, I feel. But it's also racism and the stigma and discrimination, I think ongoing sexism, the sorts of assumptions that we make about people and the rejection by services that adds to this kind of trauma is a really common experience by people with this diagnosis in particular. So other diagnoses carry with them stigma and difficulty, discrimination, such as psychosis, but borderline personality disorder in general does also add to the difficulties because people have for so long deemed it to be untreatable and therefore often turn people away, which actually does add to the trauma. You know, I think that's a really important point. The good news, I thought, when I was thinking about this suddenly, was that public mental health, it seems to me, is at its roots is looking at some of the social determinants of health. And consequently, I think it's got a massive amount to offer to people who experience these kinds of problems and who end up with this kind of diagnosis. Public health as a sort of an overall sort of policy strategy, if it was given enough resources, would be looking at some of these very things that might result in people getting a diagnosis of borderline personality disorder. And I think that, for me, was a sudden realization that there was an open door here that we could actually use. So how would we bring the trauma, the abuse and the neglect that people experience out of the shadows and into this world where this public mental health strategy might be of use to people? In terms of prevention, I'm thinking improve early childhood experiences. There used to be a thing called Sure Start, which was about maximizing the resilience of parents to be able to care for children in a very positive way and to overcome some of the disadvantages that some children are born into. And I think those sorts of things have very much dissipated over the years, particularly under Tory governments. Actions to reduce poverty, racial and gender inequalities, and to sustain communities. I was really delighted to hear Ray mention peer support, because peer support around mental health is something that is really close to my heart. And recently I've been talking to people who are participating in peer support groups, and particularly for people who've experienced sexual abuse, and the power that those groups have to listen to people well, to be able to listen to abuse. We are, as a society, generally no good at listening to abuse. And other people who've experienced it can hear people who have experienced it. That power of peer support is really, really important, I think. Actions to acknowledge and work with trauma, abuse, neglect across community. So again, it's just really recognising that not all trauma looks the same, and a broad understanding of the different things that have affected people. So one of the things that affected me in my teenage years, young teenage years, was that I was in 2 different road accidents, which left me with an abiding belief that I could feel that I was dying. I felt that I was dying. That I still have that with me. Sometimes it visits me in nightmares and that sort of thing. But quite often when services and policies talk about trauma and abuse, it's often talking about sexual and physical abuse within families, and often doesn't include those kind of complex, those other sort of external life events that suddenly impact upon you. And I think those are just as important as some of the really significant ongoing traumas as well. Finally, I'd just like to say how very important it is and how wonderful it would be to have a whole programme led by people with lived experience of receiving this diagnosis, and to hear their understanding, to hear our understanding of why we think we ended up with that diagnosis. How did we get there? And again, I referred back to Ray's talk and his mention of epistemic injustice, because one of the most significant causes of our continued oppression within society and within services as well is just the societal belief that people with a psychiatric diagnosis or mental health challenges are not credible reporters or witnesses of our own experiences. When we speak, we're so often not believed. Thank you very much.
Thank you so much, Alison. That was brilliant. I'm really glad you could join us and present that. It's now my great pleasure to introduce Anna Bergvist. Anna, this seminar and the doctoral program and the other research that we will come across is very much a combination of Anna and I just really wanting to do something different and interesting. So Anna is Associate Professor of Philosophy, specializing in meta-ethics and in particular moral perception, philosophy of psychiatry and applied phenomenology concerning self-ownership and relational moral agency. She's the editor of Evaluative Perception with Oxford University Press, and has also published on shared decision-making and cultural values in psychiatry. Her service to the profession includes acting as Secretary of the World Psychiatric Association section for Philosophy and Humanities in Psychiatry, a post that she has held since 2020 and still holds. And she's an executive committee member of the Royal College of Psychiatrists Special Interest Group in Philosophy. She's also a director of the Values-Based Theory Network at St Catherine's Collaborating Centre for Values-Based Practice at Oxford, and a member of the Whiteness and Race Equality Network. It's a real pleasure to introduce Anna's presentation, in particular because this initiative is firmly jointly hosted in the world of philosophy, and one of the important things about hosting an event like this with philosophers as well as clinicians, practitioners and people with a range of lived experience is that it marks this out as thinking space, and I'm really looking forward to Anna's presentation as a kickoff point for a different stream of thinking. So Anna, the floor is yours.
Anna, you're on mute. If you could unmute and share your screen again, please.
Okay, so this is one of those.
That's working perfectly. Thank you.
That's working fine, and you can hear me okay as well, I hope.
Yes, we can.
Okay, so thank you again, everyone, for coming here today. What I want to do today is to, in this very short space, seek to bring together some of the themes that have emerged so far. And I think I want to really start with the emphasis that Ray had in his talk, of really trying to capture the person behind the diagnosis. Philosophically, I think of this as the significance of what you may call the moral self, or the agent, the one who is there all along and whose task it is to manage your condition for the future. I also want to echo Alison's insightful remarks about the possible genesis in this. I won't go into my own history here today, but suffices to say that concepts surrounding intergenerational trauma and narratives that have been in some sense passed down upon you is also the one that can affect very real trauma for patients. So even though the talk is going to be fairly theoretical, I want us to think of these concepts with sympathy in a co-creative way. It's precisely this importance of moving away from various othering problems that we see, polarized contrast between, on the one hand, the establishment and so forth. So that's one thing that I want us all to think together about today. And I think I want to start with a reminder that, as it were, the establishment isn't all about pathologizing persons. This is a slide that is taken from the World Psychiatric Association's own position statement on what is to be, what is expressed as the kind of new challenges for the psychiatrists of the 21st century. And what you find on this list here is, I think, all items that point towards a reappraisal of self-management, but also a strong sense of patient empowerment, and doing so as a way of enabling the patient, as one of the items is stating here. So the language here is very much one of facilitating recovery. And the item that I want to focus in on today is specifically this notion of the role of the patient and the team in recovery. And the emphasis of team here, I think we can use by extension as a task that brings with it a holistic conception of society as a whole. If you think of the biosocial determinants of mental health and illness, it's no exaggeration to say that it is a wider systemic approach is very much overdue. One that I personally think of one as expanding, or indeed moving, the quote-unquote illness out of the patient and thinking further about the wider opportunities for the self behind the diagnosis, and doing so in an essentially relational manner. whereby it's the social context that is one that needs to change in some way. Okay, so on that note, here is just an excerpt, just a reminder on this idea of hope in recovery. This is a quotation from Hannah Pickard in her essay Stories of Recovery, the Role of Narrative and Hope in Overcoming PTSD and Personality Disorder. And I picked this because of its emphasis of narrative as an ongoing and open-ended process. So, and I will quote this at full length. Good practice in care demands that clinicians do whatever they can to help patients tell their own stories with hope in order to best promote recovery. The most straightforward way of doing this is for clinicians to hold hope themselves for their patients, to believe in their patients' powers of choice and agency and their capacity to recover and lead a better life. Communicating this belief, persisting in it despite lack of good evidence and in face of the patient's own resistance or despair, and trusting the patients even when their patients do not trust themselves, is something that can help to engender hope in patients themselves. It is a truism that we are often only able to believe in ourselves if others believe in us. So notice here the really strong emphasis on relationality right from the start here. There are a number of questions we can ask about this reappraisal of relational processes as a way of affecting better progress. So first of all, we can ask what this emphasis means for clinical care. Well, one thing we can say here is that is the renewed interest in shared decision making based on the individuality of patient values alongside good evidence, whereby the relevant management and so forth is itself procedural in the sense that it should be established through empathetic dialogue, where the purpose of such open-ended mutual dialogue is to facilitate recovery. And this, I think really takes us back to Ray's initial prompt here. This idea that recovery is itself something that speaks to a restoration of the quality of life from the point of view of the individual patient, given their stories and situated ecological systems. So I think that's the hard, the real challenge for a public mental health as I see it. Now, there are a number of concerns that we can raise straight away. What about burnout? What about risk management? Not to mention wider power problems in society to do with epistemic injustices, gender inequalities, and so forth. I take it that those concerns are very much visible on the scene as something that we can't shun away from in taking the challenge for developing a new public health approach along these lines seriously. So I just want to note where I take some of the challenges to be here. I won't talk more about that myself here because my expertise isn't clinical care. My expertise is rather one of conceptual analysis as a philosophy. So a few things that I want to emphasize here from a philosophical point of view is really some of the lessons that we can take from social epistemology in mitigating against what is sometimes referred to as epistemic injustice. This idea that we need to take the patient's seriously as a credible knower. And in doing so also requires an emphasis of the reality of the lived experience of mental illness, if we want to use that word, from the point of view of the person in question. And I think that's really such a powerful tool that we have at our disposal with the renewed interest in lived experience as expertise. Start with the story, start with the concerns raised from the point of view of that story, and then work backwards to see what the relevant new requirements are. So if we have that view of the subject as precisely not merely a pathologized person who may themselves feel that type of othering from the profession, but really reappraise the person as a stakeholder, as a knower, and also in the knowledge production that we may call co-creative research. So that's the second item here. And there is a third dimension of moral agency in understanding the experience itself, and indeed self-knowledge through the use of language as tools. Indeed, if we remember what Ray talked about this morning, it's very easy to self-stigmatize yourself if you, as it were, come to internalize a certain type of pathologized patient narrative. So narrative here can work both ways. It can precisely work against empowerment if you, as it were, internalize the wrong type of language. But it is precisely by making those implicit conceptual commitments explicit that we can also use language as a tool for empowerment, education, and indeed also communication. So yeah, just a few items that I'm interested in as a philosopher, and we can think of them as all belonging to social epistemology, where the type of orientation here is informed by this emphasis on perspective taking and what that risk of perspective taking means for us. Okay, so I think we have some sense of what the challenges are here. So I'm going to give you a new challenge. This is thinking forward with our initial idea of recovery in the context of personality disorders. So here is a puzzle that Hannah Pickard raises in her article that I want us to think through in the time that remains. So Pickard writes, although the hope and belief in a better future no doubt increases the likelihood that it will be realized, clinicians must nonetheless occupy two opposing stances that are difficult to rationally reconcile. They must have imagination faith when using narrative understanding to support patients in recovery from personality disorder, and at the same time maintain belief in their patients' power of choice and agency. Yet, at the same time, they must face the evidence that suggests that their faith is misplaced and their belief unwarranted, because only then can they help patients create a vision for a new, better life that is realistic to achieve. Even when clinicians and patients are alike succeed in effectively striking this balance, their hopes for a better future are often dashed. Okay, so I guess here we have this real fear of risk management. You know, here is my patient, they have had so many suicides, I'll give up. So I want to move away from that, from that perceived incompatibility here. I'll come back to this in a minute. I think in order to move away from that kind of rational conflict, I think it is important to reappraise this idea of perspective taking. And in my own work, I follow Iris Murdoch on this point, simply in reappraising the significance of a wider holistic background for our everyday cognitions. So when we're dealing here with patient and doctor relationships, and if we're doing so in a genuinely relational way, there is an element of trying to operate at a horizontal level as opposed to the standard hierarchical structure. And that in itself involves a risk on both parties, a risk of precisely being seen for who you are by the other. Conceptually, we can formulate two conditions as follows. The first one is an epistemic no priority claim about knowledge in intersubjective empathetic inquiry, whereby neither perspective of the parties involved is prioritized over the other. Now, this doesn't mean that anything goes, but it really speaks to the importance of listening. You know, before you put somebody in a certain diagnostic box, you need to appreciate the person in question. So that's really what is meant here. That in order to engage with the other, you need to, in some sense, try to see the world from their point of view. The second claim that I wish to propose is about the meaning of individual concepts, be it illness, be it being a patient, be it being defiant, and so forth, as something that itself plays a role within the wider interpersonal systems in which they operate. So the simple point here is that there is no such thing as a patient in a vacuum. You know, you become an inpatient given a certain context. And likewise with the notion of expertise. And I will return to that point towards the end. Okay, then, so what this means then is that we have new tasks ahead of us in engaging with the other, but also a type of challenge in, morally speaking, in attaining this knowledge. And the reason why the challenge may be seen as morally complex here is that it requires us to adopt a certain stance towards the other, an empathetic stance where you really want to engage in a dialogue, where you wish to engage in a relational process in order to see things right. And that's, when you actually start thinking about it, is harder than it may initially sound. Okay. So those are some of the conceptual ideas that I am interested in here, really in as a way of understanding some of the significance of what has been said in previous talks today. To make this a bit more concrete, here is two different ways in which we may conceptualize some of the challenges about regulation that Ray alluded to earlier today. This idea that part of the challenges here can be one of striking a balance in ways that are appropriate to circumstances. So here is a fictional account of Martha. Martha is an adult patient, an adult inpatient diagnosed with borderline personality disorder. And this, I think is quite a common representation of how borderline patients are in terms of their identity disturbance, so-called, and also the perceived challenge in terms of moral agency. So I will read this quote in full because it matters in what follows. And I quote, "Within Martha's narrative of her life history, overdoses were the things that happened. They were the final event in a coherent and well-organized sequence of events that made explanatory sense. But they were not things she did. For instance, when asked in group to describe the lead up to one of her overdoses, Martha eloquently explained how, feeling overwhelmed and like she could bear life no longer, she got into a car and went to buy alcohol and tablets before driving to a secluded place, only to conclude, and then there was an overdose." End quote. When the group questioned her about why she did not say that she then took an overdose, Martha became defensive and distressed and rushed out of the group. When she returned, she initially refused to speak to the group about why she had left, but when pressed, reported that early childhood feelings of being the black sheep in the family had been triggered by the group's questioning, and that she had been scared of suffering flashbacks as a result. Now, a couple of things to notice here. So this is a made-up example that is designed to highlight some of the challenges to do with agency, and indeed one of a disconnect between what you may endorse, narratively speaking, as your aim, as your identity, and things that you do as a result of your condition. So this is a typical representation as to how persons with BPD in particular, they're just in it for the ride, they don't take any responsibility for their actions, and so forth. Okay, so bear that in mind, and now contrast that with the following report. This is a self-report from a person on a peer forum. So this is a peer support forum for borderline personality disorders. So you can think of this as a kind of just ask for advice from your peers. Yeah. So here is how this self-report in a similar vein was put on this forum. And this is an authentic self-report, I should ask. I quote again, "I keep reading from nons, which I take to mean non-borderliners, that BPDers are completely incapable of any introspection. I don't agree with this. I know that I certainly have times of introspection, and I'm actually a fairly introspective person, constantly analysing myself and my behaviour. I also deny a lot of aspects about myself, but at least I am aware that there are things that I am in denial about, right? I don't know, I suspected BPD long before being diagnosed. Maybe all the reading I have done about the condition has given me better introspection. But I feel like I have always been fairly introspective. The problem for me isn't recognizing the behavior when I'm fine. It's being able to change it once I am in those emotions. I am aware, I just feel completely out of control of my actions. It's like I can still hear the rational voice, but that rational voice has zero control of me. Does anyone else feel this way? How introspective are you? Do you think real introspection is possible for borderline personality disorder? Okay, so the point of this self-report was to give you a rather contrasting story for how some of the challenges of regulation can be perceived from within. And notice here in particular how that type of representation is not one of lacking agency, it's one of being able to control your actions. So it's a breakdown rather between self-awareness on the one hand and its practical link into practical agency. Not a problem with self-identity as such, or so I claim. Okay, so I don't know how much time I got left here, but we can think of a similar story here, and this would be a similar example of how the way we describe these challenges really matters for engaging with one another in a relational way.
Anna, we're into final thoughts territory.
That's great. So I think I will leave you with that thought, and we can talk together about this in what follows.
Thank you very much, Anna. So we have a few points in the chat box that I will point us at. I think if we can start, just because it's easier and in front of me. Shari, thank you. Shari has put in quite an interesting discussion, and one that certainly you and I, Anna, spent quite a lot of time talking about, which is, is even talking about personality or disorder the right place to start? So I don't know if you can see Shari's comments from where you are, Anna, but do you want to pick that up first?
Yes, personal, I think, is a very unhelpful term. I only use it in order to engage with excellent literature on the topic. I mean, the way I would say is that any diagnosis can be useful if it helps the person's access services if they so wish to. So any diagnosis in terms of compensation, in terms of rights, that can work as in terms of justice, but as an identity category or even a defining thing, I think it is unhelpful myself.
And just to explain why we chose it, and we've put it in inverted commas in a number of places, and that was to some extent a result of Alison's presentation in Untitled. But I think the reason I wanted to explicitly talk about it is because I think there's a danger if we don't refer to these diagnostic terms, they will get left, people with them will be left out of the public mental health discussion. So it is certainly not that I buy into them, although I accept that some people do find them useful and of value. But I think the danger of not using them at all or not discussing them at all is people will just then assume that public mental health doesn't apply to these diagnostic categories. But I would also welcome Alison's thoughts, Alison, if you're still with us, and I will cut and paste Sherry's comments into the general chat, because I don't think everyone can see them. My apologies for that.
Well, no, I really do agree with what Sherry says here. I think the problem is kind of also comes to the anecdote that I told right at the very beginning, is that we get into shorthand thinking, which is really damaging. So somebody can go around saying, you know, this person is showing borderline features in this really sort of judgmental way. And I think that is so damaging. So yeah, I would rather start in a different place personally. I understand the sort of balance that people in this space right now are trying to find. But yes, personally, I would not start in that place. I would start from a very different place. I would start from, you know, what language do people want to use? And yeah, thinking about the issues of oppression, abuse, and, you know, all those things that people have experienced that has come to sort of influence their feelings, the way that they manage their feelings and so on. I mean, I do find it very problematic diagnosis, yeah.
I don't, when people are, I don't know if participants have the option of making their comments visible to all participants as well as panelists. I don't have the technical skill to answer that one. If they don't, then do. Okay, then I will, if things aren't visible to everyone, I will cut and paste them in. There was a really useful comment from Sarah Stewart Brown, and part of what Sarah talks about is the importance of talking about shifting a focus on well-being. Now, one of the challenges I have with that is similar to the challenge with using the term personality disorder, which is that so many people with a psychiatric diagnosis don't identify with that term. Now, I think that's about how it has been positioned and used. And I think when I think of all the work that the survivor movement has done around people who have had diagnoses foisted on them, so much of what we're talking about is actually just improving our lives through what you might well think about as well-being, and by addressing social determinants. Alison, I was really struck by your social determinants slide, and I think that in itself is the one really useful stepping stone between this, the current language of severe and enduring mental illness, SMI, however we want to phrase it, and all those diagnostic things that are bundled under that, and the public mental health area, which still feels other to people like you and me sometimes. So it's how do I thought your slide was really helpful in starting to address that, because there was nothing on that slide that we couldn't have been talking about in Survivor Speak Out back in the 80s as really important things for the survivor movement to be addressing. Yeah. I don't think we'd have had the language of social determinants, and we certainly wouldn't have had the language of public mental health. But I just commend you for using that as a stepping stone. And I wonder, if Sarah has any advice for us as well about how we can make sure that the language of well-being isn't dismissed as fluffy, but is actually absolutely core to how we should be. My personal mission statement is making the world a better place for mad people. How do we embrace the key components of public mental health to enable that to happen?
If I can come in here, actually, David.
Of course, Anna.
And this really goes back to the initial observation that, after all, personality disorder, they used to be seen as untreatable conditions, but that's partly because there is a certain bias towards certain types of treatments. I mean, long-term psychotherapy is extremely useful. I mean, that there's no doubt about that. What is in question is that it is not accessible to many people. And I think that is itself a very important feature to public mental health, because if you think of psychotherapy done well in this open-ended relational process of externalizing processes in the public domain, and talking about it in a way that you can distinguish yourself from the processes that you have experienced. I think having that more in the public domain, both through peer support and so forth, can precisely bridge the gap between, on the one hand, intensive private psychotherapy that only those privileged can afford, and as it were, capturing some of the important aspects of self-cultivation and those key processes that are so important, especially for trauma-informed care. Again, one of moving away from pathology to understanding the story and to, as it were, repairing the story for the future in a collective way.
Lovely, thank you. I'm slightly conscious of time now, and I wonder, Anna, if you could give us a brief introduction to the doctoral studentship. and explain how that sits with the seminar series and what opportunities it offers for people now. And I will, I'll share any links to that as well in the chat.
Okay, yes, so so let me see, I got maybe a bit too many slides here, just 1 second. Oh, stop. Is this sharing now? I can't really see.
It's just started sharing now, Anna.
Yep, we can see it full screen.
That's great. So yes, myself and David have recently been successful in securing a fully funded studentship from the North and the HRC Northwest doctoral training partnership. So the title of the project is Lived Experience and Personal Values in the Philosophy of Psychiatry, Reframing Evidence in Developing a New Public Mental Health Approach to Serious Mental Illness. So that's the long title of the project. But it's the important thing here is that it's a salaried PhD studentship with an October 21 entry. The deadline for applications at the moment is the 22nd of February. It will be co-supervised by myself and Dr. David Kravesky. The project is precisely the type of processes that we have started to address today. The first and foremost is one of understanding the role of patients as experts in the emerging discipline of public mental health and associate models of person-centered management, thus understood as one that is geared towards the restoration of well-being, quality of life from the point of view of the person in questions. So that's the kind of the main focus of the project. It is a project in philosophy, but other backgrounds are welcome. So the project sits in philosophy, but it is one that runs in very clear practical application together with Mental Health Foundation. Another thing to note about it's a generally interdisciplinary collaboration. I myself in Manchester work with the Manchester Mental Health Research Group, which is led by Professor Joy Duxbury. She has worked for minimizing restraint and so forth for many years. And Joy and I have also recently been successful in securing a major grant for improving the Mental Health Act. That's a project that has focused on BME, but the candidate will also get some insight into some of the wider work that goes on surrounding co-production in related domain. Another notable feature of the interdisciplinary nature of the studentship is its operation. So the operation will be a shared workspace, which is a platform for research and supervision. I mean, nobody knows what will happen with COVID yet, but the successful candidate will help establish a new pilot North England hub on behalf of the Mental Health Foundation. And they will do so alongside administrative support from the Foundation's office in Wales, and there will also be placement opportunities in the main office in London. So that's so it's an academic project, but it's one that really works outside academia. So you don't just have to sit in your room and write on philosophy. And again, it's a jointly supervised project together by myself and Dr. David Kravesky. I think I want to probably open up the floor here. Let me just see if there's anything in particular that I want to say that I haven't said already.
I can't see any. I mean, if people have questions specific to the doctoral studentship, please jot them in now. I've tried to cover off all the questions I've picked up in chat, but I may have missed some as we've gone along. So if anyone has any final thoughts that they want to put in, please do so now. While we're waiting to see if any further comments come in, I think we can start to wrap up today's seminar. Firstly, I'd like to thank everybody. Okay, we've got a question about how are the seminar series and the doctoral program connected. Anna and I are working on a kind of broad research topic, which is this process of understanding the relationship between public mental health and what gets called severe and enduring mental ill health. And what we are the way we're doing that is that we can we are pulling in a large range of resources to help us do this. So one of those resources will be a series of seminars that will be jointly hosted by Manchester Metropolitan University, who co-host the doctoral studentship with the Foundation, and co-hosted with the Collaborating Centre for Values-Based Practice, who are our host for today's seminar, and the Mental Health Foundation, which is my organisation. So we three organisations are we have committed to running a series of seminars over the next 4 years on this topic. As part of gathering resources to research this area, Anna largely with some input from me, which I think was marginal because Anna worked her socks off on this one, approximately 23.5 hours a day at some points, I think. So we successfully achieved the funding for the doctoral studentship, and that will also contribute to this overall research project. Our goal is to have completed 2 of these seminars by the time we have the doctoral student in place, so that they will have some source material to start to work with, but then they will have an active role in being able to support and develop the learning that comes from these seminars. We also see these seminars as opportunities to draw in additional partners. So we have talked to a number of other organisations who weren't able to join us today, but will support both the doctoral initiative and the seminar series. But Anna and I are continuing to work on other sources, other resources to bring to this research project, and we will certainly be looking to publish papers and other publications around this area. But we're also very keen to hear from people who are working in this space, who some of whom might not recognize either the language of philosophy or the language of public mental health, but we think are just natural partners for this. So that's how I see the link out. And just one minor point on the hosting of the doctoral student. It will be from the Foundation's point of view, it will be primarily in London, with some visits to Wales, coronavirus permitting, rather than the other way around, just in case I have some very panicked Welsh colleagues on this call. So but they will largely be sitting at Manchester Met, and then we will be co-hosting with the Foundation, and Anna and I will be providing the bulk of the support. Anna, is there anything you want to add that I've missed on that, while I quickly scan the chat box for any final bits and bobs?
Not really. I mean, the only thing that I would say, well, 2 things really. So one is that the studentship is one that it's, as I said, it's a theoretical one, but it's one that is precisely not limited to academia in its processes. So, and you will not be doing this single-handedly. It is very much something that we think of as a team effort. And the way I see of it myself is also part of a wider project for the future. So I would encourage everyone who haven't already been in touch with myself or with David to get in touch, because one thing that we both want to do is to continue to build this community for collaborative working.
Lovely. Okay. Well, I think that brings us more or less to a natural close. I don't know if Bill or Ashok want to add any closing remarks from the Collaborating Centre perspective. You would be very welcome to do so, but no pressure if you don't. Once again, I'd like to thank everyone for joining us. A personal thank you to Sarah Stewart Brown, who's been very, very helpful for me developing my thinking on this, and to all of you who've made contributions so far. If there are, we will make this seminar available for you and others to view. It may take us a little while to do that, and we'll also write up some notes and distribute that as well. So if this is of interest, if this is of interest to you, and if you can think of colleagues, friends, family that this is of use to, please pass on details of that. We'll be setting up an email network to do that. And just one kind of final thing to note, from my point of view, as a kind of survivor academic, as I suppose I'm reluctantly think of myself of now, it's lovely to be on a panel of 4 such highly qualified academic people, all of whom have very strong experience of using mental health services, of receiving diagnostic labels, and bringing a really strong combination of personal perspective and academic perspective to it. And for me, it's really important. We don't particularly talk about this as a survivor-led initiative, which is the language I grew up with. But for those of you watching, you should know that each of the 4 key presenters is doing this from a very strong personal background, as well as an academic background. And I think it's a credit to the Collaborating Centre, to the Foundation, and to Manchester Met that they are supporting an initiative that is led by people who historically their knowledge has been marginalised and not taken seriously. So I appreciate the opportunity to use this platform, and I know others do as well. But thank you very much for everyone's contribution. I've heard nothing from Bill or Ashok, so I shall very happily.
So David, I am here.
Oh, excellent. Is it just that I haven't paused to breathe and let you in?
No, that's all right. I just wanted to say, look, thank you to Ray and Alison for fantastic contributions, and to both you and Anna, both for contributing and also getting this set up. And I would absolutely echo what you said, that having a platform with survivors leading the project is absolutely crucial, and is a direction of travel that we would very much welcome in the Collaborating Centre, not just for this initiative, but for our other networks. And so I just wanted to thank all 4 of you, thank Mihir for all the techie work in the background. And of course, the great thing is that we have this recorded now, and it will be back up on the site. So others who couldn't join us today can benefit from it, and it will be hosted on the Collaborating Centre website. So I think congratulations to all of you on a fantastic launch of this series of seminars. And I'll certainly be prioritizing the rest in my diary, having heard what I've heard today. Bill, I don't know if you want a last word on that.
No, I'd like to echo what Ashok said about the overall way in which this has been positioned and how much we value it in the Collaborating Centre as an initiative. I was conscious as we went along that psychiatric diagnostic categories were getting a bad press, and probably deservedly so. And I say that because I think there's a growing recognition within psychiatry itself that these diagnostic categories don't work in psychiatry in the way they do perhaps in other areas of medicine. Ashok, you'll correct me, but I think in surgery, diagnostic categories work rather well. And I don't know if any of you managed to see, there's an open access publication called World Psychiatry, which is the publication of the World Psychiatric Association. I think, Anna, you mentioned that you're secretary to the Philosophy and Humanities section in the WPA. The WPA is very forward-looking in a lot of respects, and the World Psychiatry Journal, although very much aimed at psychiatrists, is also very forward-looking. And one of the big issues that the journal has picked up in recent editions is about the move away from narrow diagnostic categories. I don't think they've talked about personality disorder yet, but they have talked about other areas of what David calls severe and enduring mental illness. And there have been two big review articles recently, one on depression, the other on what they call primary psychosis. And the idea is that we should, even within medical psychiatry, start thinking in terms of broad areas of difficulty that cut across traditional diagnostic categories, rather than sticking with the traditional diagnostic categories. So I think there'll be a ready ear within psychiatry, certainly within the more academic areas and cutting edge areas of psychiatry, for approaches that don't depend on and actually may have difficulty with traditional diagnostic categories. Alison, you rightly mentioned the extent to which personality disorder in general and borderline personality disorder in particular are used almost as terms of abuse. And I think what Anna said about the evaluative nature of language is incredibly important to us here. And of course, it's one of the reasons why we're a collaborating centre for values-based practice, because we recognise, and this is for surgery as well as psychiatry, that the way in which values come into our practice is crucially important to how we work with as patients or survivors and as clinicians or service providers. I think that's come through very strongly in all of today's talks. And I think we'll see a lot more of this, not only in organisations like the Collaborating Centre, who are, although based in Oxford College, I wouldn't say we were central to the medical ethos, Ashok, would you? I think even evidence-based practice struggles when it comes to values-based practice. We're still in the margins. But the fact is that there are some very encouraging signs within medicine and within medical psychiatry that I think open up a space for the kind of considerations that have been presented so forcefully today by our speakers. So to echo Ashok's thanks and to say this is in many ways a very exciting program, and we're delighted to be involved as host for part of the program. Thank you.
Okay, I think that's the end. Last word to you, David.
Thank you very much, everyone. Thank you particularly to Mihir for all his sterling work in the background, for keeping us on track throughout these challenging technical times. Thank you, Ashok, and Bill, for your support throughout this process. And thank everyone for being here. We will be in touch with you all for the next seminar. Please have a look at the doctoral program if you're interested. Share the information. And thank you very much for joining us, and have a nice lunch. Bye.
Thank you very much, Bill.
Bye-bye. Bye.
Bye-bye.